Today, we are going to be discussing metastatic colorectal cancer and specifically the results from the Collision trial. Abstract that we're going to be talking today was presented at ASCO last year in recent publication in The Lancet this year. To help us with this topic, we have Dr. Martijn Meijerink from Amsterdam UMC. Martijn, how did I do with the name?
That's all correct. You did perfectly.
Thank you, sir. Thank you. We were joking offline about like the biggest worry of my day was actually getting your name right today. All right, so we'll just start out with introductions. Most of the audience knows me, Chris Beck, interventional radiologist out of New Orleans and private practice. And Martijn, can you give us a little bit about your background and what your practice looks like today?
Sure. So Martijn Meijerink, I grew up in the east of the small country of the Netherlands, in a place called Enschede. I moved to Belgium for my medical school, so I lived for 8 years actually in Leuven, which is a university center there. And then I moved to Amsterdam for my radiology residency, and after that my interventional radiology training. A long time ago now, I guess, but currently doing mainly interventional oncology procedures. When I'm on call, still some vascular works, and of course the hemorrhages and the normal things that you would expect in the middle of the night. But my main focus is interventional oncology, and I am what they call in Amsterdam a primary investigator. So this means that I guide a lot of PhD students, candidates in their research, and I do a fair amount of clinical trials in the field of, tumor ablation, specifically liver tumor ablation.
Cool. And just to get a little bit more granular, so in a given week, if you're on procedures, not research work, what are you doing as far as what are some of the treatment modalities or what are some of the procedures that you're doing in a given week?
So because I mainly focus on interventional oncology, sorry, let me get that one out of the way.
No problem.
Sorry. So my main area of expertise, I guess, is ablation. So a large part of the week when I'm involved in clinic, I treat liver tumors or renal tumors or lung tumors using all sorts of needle-guided approaches. But I, of course, also do a fair amount of TACE procedures, Y90 procedures, what you would expect, portal vein embolizations. That's pretty much the standard of my practice. And then, of course, a big university hospital, there's a lot of biliary tract interventions, as you would expect. And, post-surgical hemorrhages, or when I'm on call for also the trauma center, and I also do a fair amount still of embolizations for trauma and non-trauma bleeds.
Okay, very cool, very cool. Solid practice. Sounds like not a bad gig that you have over there. So I wanted to, before we jumped right into the study, I wanted to just open it up and give you the mic to kind of lay the foundation for just metastatic colorectal cancer. You want to talk a little bit about the background of metastatic colorectal cancer and kind of where IR plays into treatment of that disease?
Yeah, let me try. So I think that...
Yeah, I know, right? Big question.
Yeah, well, it's a lot to cover, but I think when you look at metastatic colorectal cancer, what makes it completely different to other metastasized malignancies is that there is, even though it's a relatively small chance, there's still a chance for full cure, especially when it's localized in the liver. There still is, let's say, a 20-25% chance that if these patients eventually are eligible for surgical resection or ablation, but we'll get to that point, there's a fair chance that they will eventually be fully cured. And that makes it different to other disease entities, I guess, in oncology. Of course, if it's more advanced, this is where we can play a big role using transarterial techniques as well. But I think that the role of interventional radiology, if you look 20 years ago, where we would rarely help out a surgeon with a deep-seated tumor that he could not resect, and I mean transarterial therapies back then for metastatic colorectal cancer, they did not exist, to where we are now as let's say, at least one of the first-line options for oligometastatic disease, and also a growing role for transarterial therapies for for more advanced disease, it is something that I guess that interventional oncologists should be, well, not enthusiastic about, because we're talking about metastatic cancer patients, but at least they should focus on the background of that disease, the biology of that disease, and they should probably, I think, know what the correct indications are, when to do an ablation, when to do a Y90 treatment. I think that our role is really growing, and it will be bigger in the next 10 years.
Okay, well said. So let's jump into the study. No point messing around. Can you introduce the study and talk a little bit about, I think that's a good place to start. Just introduction of the study.
Yeah, maybe it's good to go back to where it came from, because, and I'm guessing this is the same in many centers throughout the world. When we started doing these radiofrequency ablations for tumors that the surgeon just couldn't resect, it was very often, really late when they called you. They tried to resect, didn't work. Then you have to go, you were not it's not in the agenda, but you have to go to the OR, then do the radiofrequency ablation. And then we had a lot back in those years. We had a lot of local recurrences. But getting to know the surgical team better and better, and actually planning these procedures made us a lot better. And I'm talking about the early 2000s now. So slowly, I think that our local recurrence rates that were honestly in the early 2000s over 50%, I'm speaking for myself, but I'm guessing in many centers, they went down and down and down. And now with the techniques that we have, I think that we fairly often in the MDT had the discussion, well, but you could also, I can resect it, but it would require a major hepatectomy. I can also, why don't you do the ablation? Obviously, because it's another specialty, it requires a lot of trust and a close friendship that I had with the surgeons. But this is where sort of the idea was born, to set up a randomized controlled trial. I think that society-wise, we have been talking about a trial like this for 15 years. And I was frustrated that it took me so long to find the funding for the trial and the people and all to convince all the surgeons. But to be honest, I think that we would have failed if we would have done this 15 years ago. We would have had a very high number of locally recurring tumors, and we would be bashed for that, and we should have been bashed for that. I think that with the advancements and the innovations that we now have, with the techniques to guide the needle, with the confirmation software, with the, let's say, the devices that create way larger ablation zones, the timing was correct to start the trial. We started the trial a long time ago, though, so the first patient included was, I think, early 2017. I still think that the ablation is improving by the year. You can see that. But I think it's a good thing that we started the trial in 2017. So the trial is, if I can continue, the trial is...
Let me,
yes.
There was one question that did jump out to me. Like, you mentioned improving techniques, and maybe this is included in techniques, but anything to comment on improving technology? You mentioned RFA. Any commentary on RFA versus microwave?
Well, yes, because I think that we still have most evidence for radiofrequency ablation, where I think that many centers throughout the world have, switched to microwave ablation. To be completely honest, that's in large part because it's much quicker and creates larger ablation zones. For HCC, we had 3 prospective randomized controlled trials negative. So in a way, it was not superior in the let's say 5, 10, 15 years ago when compared to radiofrequency ablation. There's a retrospective comparative series that microwave ablation is somewhat better to radiofrequency ablation, published as well. I think it's just, it creates in a much faster time, it creates larger ablation zones, and it pretty much does the same. It creates coagulative necrosis. So radiofrequency ablation, I used to say that there was still room for RFA, for example, when you're closer to the bile ducts. But honestly, I have not used radiofrequency ablation myself. Well, for musculoskeletal, yes, but for liver tumors, I think it dates back to 2016.
Okay. All right, fair. Just wanted to pause on that point. But no, continue. Tell us a little bit more about the study, and sorry to break your flow.
No problem. So to avoid the discussion, radiofrequency or microwave ablation, and because this was a multi-center study, and of course, These centers have different devices. We call it thermal ablation, but this means radiofrequency ablation and microwave ablation were allowed. The vast majority was treated with microwave ablation, though. It is a non-inferiority randomized controlled trial. And what that means is that the idea was not that by doing the ablations instead of surgical resections, that we would have a superior overall survival. That could have been the outcome. But the idea is if you have a less invasive technique with potentially a lower number of complications, this is where you set up non-inferiority trials. Non-inferiority regarding the hardest endpoint, overall survival. Of course, you also have to confirm then that you are less invasive and that the complication rates and the hospital stay and potentially also the costs and quality of life are superior with that new technique. So this is pretty much the trial design. I think I can continue there. So we included 16 centers, but there were 14 centers actually treating patients. It was allowed for patients to enter the trial if they had up to 10 liver mets. That was based on the CLOCK trial that many of the interventional radiologists from the community will know. In that trial, it was allowed up to 9 liver mets. So up to 10 liver mets only in the liver, so no extrahepatic metastases allowed. And then if the, preferably all, but at least the majority of tumors was eligible to surgical resection according to a panel of surgeons, and to radiofrequency or microwave ablation according to a panel of interventionalists, this patient could theoretically enter the trial, and we would discuss the trial with the patient.
Can I pause on that point and just talk about, so I don't know if you had insight or if you were on the panel of the IRs or the surgeons, but can you give us some insight of like what would be accepted as like a good location for both resection and ablation, and then what might be excluded?
Well, thanks for asking that, because I hear a lot that now that we have a positive result from the Collision trial, maybe I'm going to consider ablation for deep-seated tumors. The trial is actually focusing not so much on the deep-seated tumors, because this is where the centers, at least that have included patients, for more than 10 years already think that for deep-seated tumors, thermal ablation should go first. So yes, to answer the question, yes, I was in the panel. I think what really helped that there's a publication on that. Before we did this trial, there's a publication on the LAVA trial. That is a trial that failed to recruit patients, but they have a publication on why they failed to recruit patients. It's a UK trial. There were also some centers in the Netherlands involved. But I think in 2 years' time or so, they recruited approximately 11 patients. But in the publication, they say, it's just because of the prejudice of the person speaking to the patients, which of course in most situations will be the surgeon. They say if you do not go into the trial, I will be able to resect it. If you enter the trial, you can have an alternative technique, and we don't know if it has the same outcomes. It's way more difficult to recruit patients if you do it like that. So they say it is prejudice that surgical resection is superior regarding local control. So we decided it should not only be that one medical specialist talking to the patient to decide what is best, because we're doing the trial because we simply don't know. So let's, before anyone sees the patient, have that discussion in an expert panel. The surgeons are not allowed to say what they favor. The only question they were allowed to answer is, can you resect that tumor? Is that and of course within acceptable safety limits, but very often they said no. I think this is too deep-seated. It really needs to be ablated. And sometimes they say this is superficial. I can resect. And then that question goes to the interventional radiology panel. We are not allowed to say if it's resectable or not, or whether we prefer resection. We were just allowed to say this is ablatable. And then if a certain number of IRs and a certain number of surgeons agreed that it was both resectable and ablatable, that patient was eligible, and only thereafter the trial was going to be discussed by either the surgeon or the interventional radiologist.
Okay. When you were on the panel, can you give some examples on some things that you said, or some locations maybe that you said this is not ablatable?
So honestly, the other way around was where we had most discussions.
look, I have no doubt. I have no doubt.
Well, I
But
think
that is kind of the question I wanted to get at. Like, were there a whole lot of opportunities where you said, okay, we're not ablating this because it's I don't know, next to the heart, next to a blood vessel, and I'm worried about heat sink.
yeah, no, for sure. So there are a lot of contraindications for ablation. I don't think that that most patients that were in the expert panel, they were by the local team already considered eligible for ablation. But if a tumor was too close to the central bile ducts, that is the hardest contraindication. Because the tumors also had to be resectable. If resection is possible for those tumors, please do the resection, because if you do a microwave ablation of the central bile ducts without any cooling or special techniques, you may end up with serious complications. And then, well, it depends. Distancing using, pneumo or hydrodissection was allowed, but only if, based on the CT scans or the MRI scans, it looked like an easy distancing. If it was really a hard struggle to get that stomach or that colon out of the way, we would reject and say, no, this is a super easy case for laparoscopic or robot laparoscopic resection. Let's not, do everything we can to get the patient in the trial. Surgery is very often simply the best solution. So that's those are two examples.
Okay. So also getting to the patients, a little bit about discussion about patients. I think I read in the trial, ECOG 0 through 2.
Yeah.
Okay. Less than 10 lesions. I don't think we mentioned yet lesion size.
So it's up to 3 centimeters. That's based on most guidelines. I think that maybe we can cover the future trials. That 3 centimeter limits that first appeared in the guidelines, I guess, 20 years ago. I think with the advancement of all the techniques, I don't know. What do you think? I think you agree with me. It's not that hard to ablate a tumor that is 3.5 centimeters. So I think that slowly we need to stretch that a little bit. But within the trial, it was really strict, of course. It was 3 centimeters upper limit.
Okay. And so upper limit, so longest dimension, 3 centimeters, and it could be measured MRI, CT, whichever modality saw it best, maybe?
Yeah, so I think that in most cases, the CT was done before the MRI. So if it was, in a patient without any previous chemotherapy, very likely it was just a couple of millimeters larger on the MRI. But the largest diameter counted. We did have some patients where after the inclusion and randomization, you go to the procedure 4 weeks later, and then it's beyond 3 centimeters. In all those cases, I think, I'm doing this out of the head, but I think in 4 patients, we had at least one tumor over 3 centimeters, but below 4 centimeters, because then we would stop. But below 4 centimeters, we decided to ablate them, and at least these 4 tumors were radically ablated within the trial.
Okay. So I want to talk a little bit about ablation technique, and specifically percutaneous ablation, laparoscopic, and open. And whether, like, how those were, just paint a little bit more color on that for me.
Yeah. So because we needed to have high numbers and a lot of centers recruiting patients, and there was a very vivid discussion, especially amongst surgeons back in those days. Should you do it open? Should you do it laparoscopically? Should you use the robot? But the same goes for the interventional radiologists. Should you do it percutaneous versus open? So we decided to leave the approach. This is formal. I'll get to a more concrete answer. Leave the approach to the local center. So the local center could choose what they thought for that specific tumor, what is best. A lot of the discussions actually in the panel were about whether we should do it percutaneous or laparoscopic or open or robot for the surgeons. But that was not a question from the trial. The only recommendation that was there is that the least invasive technique possible to treat that tumor should be favored. And what you see in the trial is, again, I'm doing it, out of the head, but the number of patients in the surgical resection arm that had robot laparoscopic or laparoscopic resection is very high. It's higher than what you would see normally in nationwide registries. So it's really still a very modern trial. And the same goes for percutaneous. I think that over 80% of the patients were treated using percutaneous ablation. So the same goes there. I think that the only reason, I'm speaking now for Amsterdam UMC maybe, but the reason why we would go for an open approach is because there were close to 10 liver mets, or because there was also a very large tumor that was not eligible for the trial that needed to be resected. Because we have a subgroup of patients also in the trial. If you have one large tumor that cannot be ablated, that should be resected and has to be done using open laparotomy anyway, then we would simply go to the OR, and if randomized to ablation, of course, we would ablate all the others.
Okay, very cool. As far as the ablation technique, and maybe this is not entirely important, but you could use RFA or microwave, and operator preference on whether you do single probe, bracketing with 2 probes, just depends on lesion and operator, I would imagine.
Yeah, that's the thing is, we said all CE marked, it's a European trial, so let's say all CE marked systems could be used, but they had to be used according to the indications and instructions for use. So please don't experiment. But whether you prefer single needle with, let's say, higher power settings, or double or triple antenna systems, we wanted to avoid having operators because they're in a trial, that they suddenly had to use a system that they were not used to using. So please stick to the machine and the needles that you know best. This is actually a discussion that we had extensively with the financial sponsors, because Medtronic was the financial sponsor of the trial. But I spoke to them, for very long about this. I think that it was a good decision to allow all systems. So depending on the center, they simply used where they were most comfortable with.
Okay, understood. As far as margins on these ablations, is everyone using this, like if it's a 3 centimeter tumor exactly, is everyone thinking about the same ablation zone in terms of size? Like, is everyone on the same page as that?
Yeah, so if I understand the question correctly, so it was mandatory to report the margin of the ablation, but we started this in 2017. I can tell you the majority of centers did not have confirmation software in those years.
Sure.
So
Okay.
it was sometimes eyeballing or simply rigid registration, which works really well if you have a slider, in my opinion. But just based on where you think is the margin, the least, and you measure that distance, and that was reported in the trial. But it was highly predictive of local recurrence. So beyond 5 millimeters, I think it was a 96% something chance that you would have a non-recurring tumor.
Okay, got it. And last question, I'll be done hammering you about like all the technique and the nitty gritty as far as like how the procedure was done. But as far as like number of lesions, single session, multiple sessions, how was that chosen? I mean, it's straightforward when I guess it's like 3 and under, but I was thinking like some of these not more aggressive, but more lesions that are getting ablated. I was curious of how you guys handled that.
So interesting concept actually to do it in multiple sessions. In the trial, we treated all the patients in one session. But this was also local expertise. Percutaneous ablations, we tend to do that up to 5. If it's more than 5, it really depends. Well, first of all, aren't they all in the same lobe, and shouldn't you combine it with a resection, but then out of the trial? We slowly, go for higher numbers, but, being an IR, this is very time consuming. And I think that we create larger ablation zones, percutaneous, to make sure that we have the lesion. This is personal, but I think so. Beyond 5, I talked to the surgeons, shouldn't we do this old school, with an open abdomen, or combine it with surgical resection? I don't know. I think that 5 limit will also, especially with the new stereotactic machines, that will slowly grow as well, similar as the 3 centimeter threshold that will go up a little bit. I think that more than 5 lesions, will be eligible for percutaneous ablation in the future. In the trial, it was a single session, speaking for Amsterdam UMC, we did it percutaneous up to 5.
Got it. Okay. All right. So let's get to the results, right? How'd it go?
Yeah, so the interesting thing is that we designed the non-inferiority trial with a sample size of 618 patients, an estimated dropout rate of this and that. So we needed to have 599 randomized patients. But for a trial like this, well, it's pretty standard. You have a half-time analysis where you, well, first of all, assess whether the experimental arm is not harming the patients, in this case,
Sure.
thermal ablation, but also if you have early signs for benefit. And we predefined that we would say that it was sufficiently proven if at halftime, the chance of eventually proving non-inferiority, this is really technical, so this is for the people that are interested in statistics and epidemiology, I guess.
Everyone.
Okay, I hope. But if this was by then already over 90%, so we were already over 90% sure that we would eventually prove non-inferiority, and the complications were significantly lower in the experimental arm, and this was the most unexpected, local control, if that was at least as good with ablation when compared to surgical resection, then we would consider it unethical to continue the trial, because then we would have a significantly higher number of complications with similar local control and at least a over 90% chance of having a non-inferior overall survival. So the final results, we had 300 patients, 148 in both arms. 4 were excluded, because 2 in both arms, because in the end, it turned out they didn't even have colorectal liver mets based on the pathology or the biopsies. There were, I think, out of the head, 1 other metastasis from another side, 2 HCCs and 1 cholangiocarcinoma. So they were out. So 148 colorectal liver met patients, completely overlapping survival curves. Hazard ratio is close to 1, actually, so no trends. It's completely overlapping. Complication rate as expected, but still, it's still, well, it is very high. We had mortality, so a procedure-related mortality following surgery of 3 patients out of 148, so that's 2.1%. And we had 0 fatalities as a direct result of the ablation. There was 1 patient dying within 90 days as a result of a colon blowout, but that was because the primary tumor was still in, so that had nothing to do, it was unlikely related to the ablation. But also if you look at the, let's say the lower grade complications, so the grade 4 or 3, but also the other adverse events, they were more than double with the surgical resection when compared to thermal ablation. And interestingly, local tumor progression-free survival, we did not see that one coming, was completely overlapping. We still thought that with surgical resection, you would, this is what we anticipated, you would have 3, maybe 4% of the tumors recurring on the resection plane, and we thought we would be somewhere at 10, 14%. But it was completely overlapping as well, and if there's any trend, it was superior in the ablation arm. And then this endpoint is called local control.
Hold on, the ablation, so recurrence at the ablations, if there's anything to glean, you said it was more likely to recur at the surgical margins? Like at the resection?
Well, no, it's completely overlapping. So let's
okay, sorry.
Let's say that, no, I did say that a trend. If you look at the curves, the curve is a little bit higher. But the statisticians will kill me if I say that it was significantly different, because it was not. So
got it. Not significantly different, but okay, got it. Sorry.
But local control, so this is the same endpoint, but then allowing repeat treatments, was actually superior with thermal ablation. So, for example, if you have done an ablation, it recurs, you can repeat the ablation, you can also eventually decide to resect. We managed to locally control all the tumors that were there from the beginning on in 147 out of the 148 patients, and with surgical resection, 7 patients were lost to local control. And that's super interesting. And we're looking into this also with the monitor, the Data Safety Monitoring Board. We think it has to do with the fact that it's fairly difficult for a diagnostic radiologist, abdominal radiologist, but also for us to find resection plane recurrences. It is PET-AFib all the time. It is scattered with hypodensities. It's irregular. So by the time you are sure it's a resection plane recurrence, it is fairly big, and deep-seated, of course, because this is where the surgeons have most recurrences. And then you decide to give chemo first. This is talking about a low number of patients, and then if the chemo fails, this is where you eventually do not retreat that tumor. So this is why I think that with surgical resection we had a significantly higher numbers of local losses of local control. Am I making? Is that clear?
No,
All
it's
right.
clear.
Okay,
No, I
thanks.
think
It's
that's
so
clear.
technical,
I think you said
but
it well.
yeah.
Well, it's a little bit technical, and I think it's a little bit counterintuitive. Like I think intuitively, I felt the same way maybe as the investigators would have beforehand, that you would be much less likely to have recurrence along surgical margins rather than ablation margins. But the part about harder to detect around the surgical margins because of PET variability in that area, or it's always PET avid, and then once you have it, it's a little bit more deep-seated, maybe larger, also per surgical area, so harder to retreat. So no, I get it. I think that was clear. One of the things I also wanted to ask about, looking at the paper, adverse events, like even like I guess all grades, taking all comers. I thought it was higher than expected for the surgical arm, but I'll leave you to talk about exactly the percentage of adverse events and maybe what would be expected. Like, I don't know if you guys have data from like a national registry or an EU registry as far as what was expected, as far as like percentage-wise on those.
Yeah, maybe to answer that question, first of all, you need to know what is an adverse event and what is a complication. So adverse events is a combination of side effects that are not called complications. So it's expected following surgery, you have pain. That is not a complication, depending on the amount and how long it lasts. It's not a complication, it's a side effect, but you have to score it according to the CTCAE as an adverse event. So it's a bit technical, but if you look at prospective trials, the number of adverse events should be actually higher than the number of complications that we see in retrospective series. That's just one technical issue.
Got it.
If you compare it to surgical series, but also if you compare ablation to at least the larger registries or the prospective single arm series, it's not unexpected. I think it was
Okay.
I think 48% adverse events, but serious adverse events following surgery of 20%. That's not far off other surgical trials.
Okay, so that was around what it was expected, and okay, gotcha. All right, still getting into the results. I guess just to sum it all up, although I think you've said it in so many words. What did you think of the endpoint? Did you meet your endpoint? Did you achieve the goal that you wanted to achieve?
Yeah, well, the primary endpoint was overall survival. So the answer is yes. The problem is that we had to stop early for early benefit because we.
Well, is that a problem that you had to stop early,
Well,
or?
it's in a way it's much stronger.
Yes.
But for example, the National Healthcare Institutes, at least in the Netherlands, but I'm guessing in the US and other countries as well, they look at confidence intervals. And because you stop early, your confidence, even though it's completely overlapping, and the surgeons, this is not a question for surgeons or for interventional radiologists anymore. It's for, let's say, the healthcare institutes, the NCCN guideline committees. They look at the confidence intervals. From a statistical point of view, it would have been better, of course, to have longer follow-up, more events than the confidence interval of the hazard ratio would have been a bit smaller, but the number of complications and the fact that it was already over 90% is very strong. So it has advantages and disadvantages, but it's not like a choice. So we had to stop.
Okay, fair statement. And so I guess one of the things that I wanted to get into is like the digestion of the paper and how it fits into the context of like people who are treating metastatic colorectal cancer. I'll just start out like with an open-ended question and ask, what do you think this paper means now for interventional radiologists who are in practice for treatment of metastatic colorectal cancer?
Yeah, well, I try to stay away
Okay.
saying what guideline committees should do, but just to give you an idea of the impact that I think it should have, and it may have. As of today, the EORTC, this is in Europe, a guideline groups, a very important multidisciplinary group, coming up with recommendations. They changed their recommendation in the new, so it's published today. It's not on PubMed yet, but it will be in the near future, saying that surgical resection and ablation should be considered equally effective, and ablation is the one with a lower number of complications. So with a very good discussion. So I think that it will take time, but at least surgeons, especially medical oncologists, will be way more open to offering thermal ablation because we now have this trial. I'm a bit worried a little bit actually that everybody now thinks that putting in a needle is better than cutting a tumor out. It does require expertise. So the centers recruiting patients, the 14 centers, are already highly dedicated, experienced centers doing the ablations. So I think that we really need to have, let's say, thresholds of numbers that you need to do every year. And I advise all our colleagues to look at your results, because if you still have local recurrence rates that are above 20%, it's probably not wise to suddenly shift clinical practice and move away from surgical resection. You have to first make sure that you do a better job, get confirmation software, maybe other ablation devices, other needle guiding techniques. So not everybody does the same, has the same quality. So this is the next big step. We really need to, well, let's say, standardize, or at least make sure that everybody has recurrence rates at the very minimum below 10% on a per tumor basis.
Do you guys, in your practice, do you guys look at either the practice as a whole or individual providers as far as recurrence rates at the moment? Okay, you do. You're kind of nodding yes. So.
Well, it's something that we've been discussing for a long time. It's also, how do you say that? It's also difficult if you go by person and person, like you do worse than your colleague. So we have not done that. For now, we've stayed away from that. So the national guideline in the Netherlands demands that you do at least 20 procedures a year. If you ask me personally, I think that should probably be 50. But then if you have 10 IRs doing the procedures, that means you do 5 years still. So it's tricky. I think that at least for the Netherlands, but I'm guessing the same is true for the US. It's based on an institution and not on a person. But it's probably really important in your center to have one or two or a small group of dedicated people doing these ablations.
Sure. Can you speak to, without getting too far in the weeds, what about centers? So I don't know how it works at your location, but do these type of patients kind of funnel into a center, maybe a center of excellence or somewhere in a more urban area? Or are there still plenty of IRs out in the community, maybe at smaller, more rural areas that are doing like high-end interventional radiology with, ablations of metastatic colorectal cancer?
Well, what is a hot topic in the Netherlands is concentration of care. I guess that's everywhere. Mm-hmm. So the Netherlands has the advantage that it's a tiny country. So I mean, the furthest that you have to drive to go to a large scale. So that makes it not. That doesn't compare well, I guess, to the situation in the US, where the distances are way, longer.
It can be substantial, sure.
Yeah. So, but I just think that, well, it's known that we do a better job if you have higher numbers. So it's probably good to talk to your colleagues from those other centers and say, hey, okay, those 5 ablations, what if you do those 5 ablations and I have more expertise in whatever, varicose veins or this or that disease. You just try to let's say make referral patterns in between hospitals. I know I'm saying something that is more difficult in the US situation, but I leave it up to you if it's true or not than the Dutch situation. But I think in the future, for a disease that is elective, you can plan it, it's not an emergency, patients should be able to drive 30 minutes to the more experienced dedicated centers, in my opinion.
Okay. Well, Martijn, that's all we ask of our guests. We don't, I don't feel compelled to comment like on the whole system, but we are always interested in like local practice patterns, whether it's in, one small state in the United States or a whole country all the way across the ocean. So the other thing I wanted to talk about is it's just ablation in the context of metastatic colorectal cancer. And one of the things I wanted to get at is that, so like oligometastatic disease, I understand maybe like 3, 4 or less lesions in the liver. But the patients who are managed in the Netherlands, so if you have like about 8 tumors, 8 plus, but less than 10, so like, on the higher end of what you guys ablated, are any of those patients receiving chemotherapy or like induction chemotherapy in advance before they have ablation? I'm just curious, like how these patients fell in like the treatment algorithm, like within the context of metastatic colorectal cancer.
So we are, I think, the most conservative country in the world when it comes to giving chemotherapy. I'm aware of that.
Okay.
It's based on the two trials. I don't know if this is of interest to interventional radiology community, but there's two trials that, well, are most relevant here. It's a huge French trial, the Volvox 4 series, published by Nordlin Shea, and a Japanese trial where survival was just completely identical in the Volvox 4 series, and actually a trend towards worse survival if you give it after the local treatment, according to the Japanese trial. But I'm aware that in the collision trial, 22% of the patients had chemotherapy before their local treatment. That's very, very far off what you would do in the US and what most other countries in Europe would do. But of course, we give chemotherapy when it recurs and when it's multiple. So the thing that is different is not that fact that we do not give chemotherapy, it's just the timing of the chemotherapy that is very much different. More than 8, you started with more than 8, that would routinely get chemotherapy in the Netherlands as well.
Okay. So if there was, I don't want to say high metastatic burden, because I mean all the patients in the trial were less than 10, or I'm sorry, 10 or less, or less than 10.
It's up to 10. So
Up to 10. Yep. So 10 or less. But it wasn't clear to me whether those patients were receiving chemotherapy before they came onto ablation. But you're saying that these patients were.
Yeah, so they were allowed. They could enter the trial at the point in time where the local team thought this is the best time to offer local treatment. So there was not mandatory to give chemotherapy first, even though sometimes the expert panel said this is just too much, give chemo first. So and they very often did that. But the vast majority of patients, even though it was allowed up to 10, but the vast majority of patients had up to 3. So only a limited number of liver mets.
Okay. And outside of the trial, just curious about your practice in general. Like, so let's just take those patients who have up to 3 lesions. And they're referred for your practice for an evaluation for an ablation. A majority of these patients will not have had chemo up front. You do the ablations. Do those patients later go on to get chemotherapy?
Well, no. So we pretty much based that on the series that I mentioned
Sure.
from Northern Shea and the
Yeah.
Japanese
Volvox
trial.
4. Okay.
So they just go into follow-up.
Okay.
So I know that's really heterogeneous as well. We routinely, following ablation, we do PET CTs every 4 months. Actually, we changed that from 3 months to 4 months. Don't know if that's too long, but the first one is following a normal CT where there's no residual disease. The first PET CT and CEA is at 4 months.
Okay. Interesting. Is there no, that's a little bit okay. So one of my questions, and it may not be a great question, is should this trial change the way interventional radiologists are treating metastatic colorectal cancer?
Oh, that's a hard yes.
All right.
Yeah, no, that's an easy one. I think that it proves that if you are able to do a good job with your ablations, that you can offer your patients something that is way less invasive and associated with a lower complication rate when compared to surgical resection. This means you have to step up. So you make sure that you do a good job. Be in the tumor board, because I'm going to sound really strict here, but I mean
Let's
it.
do it.
So please, all friends from the IR and IO community, you have to be in the tumor board. For HCC, we are all there, but we also have to now be there for the colorectal liver and probably also the colorectal lung mets, wherever they are discussed. So it will change things big time, but you have to be there. Otherwise, well, I think that things will not change. And they should, for the sake of the patients, because we have a technique that just is associated with a much lower complication rate, and all the other outcomes are equal.
Okay. Martijn, so now taking off your investigator hat, and because you have a large number of these ablations under your belt, can you talk a little bit about best practices and just, or maybe just your experience, how you do the case, and whether it's bracketing tumor, single probe, ultrasound CT guidance, confirmation ablation software? Like, I just want to know it all, really.
Yeah. Well, that pretty much says a lot already. So the only thing that I really think that, well, at least in our situation, dramatically improved our results is the fact that we routinely place a catheter in the hepatic artery. So in all our percutaneous ablations, HCC, colorectal, neuroendocrine, or liver tumor ablations, we place a catheter in the hepatic artery. It's a 5 to 10 minute procedure. It's super quick. We attach the sheath and the catheter to the groin. Unfortunately, we don't have an angio-CT system, so they have to be transported, which is logistically takes some time, but it's not a lot of time. And then in the CT, you can give repeatedly bits of contrast. We dilute it 1:1. But you see the tumor much better, and you can repeat it and repeat it and repeat it by asking the technician to give just a little bit of contrast. And that makes it super easy to target small liver tumors that you simply don't see anymore. I mean, before we had this, you made a CT scan with contrast, but then during the advancement of the needle, you don't see it anymore. So you base it on anatomical landmarks. The catheter, I think, is key. And of course, it also helps you big time with your confirmation software. And if you have general anesthesia or good propofol sedation, preferably general anesthesia, you have to merge the scan before ablation and the scan post-ablation to see if you have the margins. And if you have the margins, I think, and you have a good registration, I think the chance that tumor will recur is close to zero. So margin confirmation, novel ablation devices that create larger ablation zones. But I think the key, and I do know that several centers in the US have started using the catheter routinely, for example, MD Anderson, but I'm aware of several others. It will change your practice big time. You just do a much better job.
Okay, well said. What about as far as like if you had a 3 centimeter lesion, or even like just talking outside of the trial, maybe you have a 4 centimeter lesion. Are you primarily treating with a single probe or bracketing tumors?
Yeah, so we're actually doing the Collision XL trial because you're talking about larger trials. So for tumors beyond 3 centimeters, if they are unresectable, because of course here surgery goes first, then we have a trial comparing SBRT to multi-antenna microwave ablation. I do realize that companies like Medtronic and several other ones, they do offer higher power systems with much larger ablation zones. I don't know, it's just what you are comfortable with. I would feel completely comfortable using a single antenna, but then you have to, don't...
Really bullseye,
One
right?
position is just not enough. Just do repositionings to, let's say, achieve the same, or use the multi-antenna systems for these larger tumors.
Okay, so if it's a larger tumor, you're rarely just treating with a single bullseye. You're going to like do a probe or an antenna redirect on each one and just try and get in all the spots, right?
By the way, if you see me, I hate waiting, so I change the needle position constantly. I don't know if that's typical or if I should, but my ablations are sort of interactive, doing this, like how I cook. But that I think it helps because you create larger ablation zones by doing that than by waiting, for the 6 or 10 minutes, whatever system you have.
Okay, well said. All right, so final question is just open-ended. Final thoughts, either on the paper or the future of metastatic colorectal, or open mic, whatever you want to talk about. But curious to get your thoughts, the direction of either where interventional radiology is heading, or just specifically where we're heading for metastatic colorectal.
Well, these exciting times. That's all I can say. I mean, it's one of the things we were really hoping for Y90 to have massive positive results from all the trials. The EPOC trial was positive, but modestly so. So, I'm really proud that I was involved in the trial that was positive, at least in the field of ablation. So we're stepping into the era, let's say the golden era for interventional oncology. I truly believe that. So we need way more interventional radiologists, interventional oncologists, and I think it will be bright times, but we have to make sure that we do a very good job treating our patients.
Okay, well said. Actually, I have one more question about the catheter in the hepatic artery. So you just get like a 5 French diagnostic catheter, just a 5 French catheter into the hepatic, and if you're treating just the right lobe, maybe it's in the right lobe and just little bursts of contrast during the procedure, right?
So yeah, so what we do, we place a 5 or 6 French sheet because we normally place a closure device anyway, and then go up with the Cobra. I have a certain specific order, but you probably do
Yeah,
it as
sure,
well.
sure.
So I start with a Cobra and then a glide cat Cobra, etc. Up to a sim. Very often because I don't want it to take more than 5 or 10 minutes, so I quickly do it.
Yeah,
And if it doesn't work, I just go for a Simmons one. And when it's in play, the microcath, you can use that, but that adds costs
a little
and
more of a
time.
headache.
So I rarely do that. And then I go to the CT room. Please know that in 6% of our series, the catheter luxated during transport. So if you want to see me and hear me curse, this is where that happens, because obviously I strongly rely on that catheter. So I'm really looking forward to the time when we have angio-CT systems to have it in the same room. But that's just it. I try to place it actually before the gastroduodenal. And why? That's because then a lot of contrast will go into the stomach and the pancreas and the duodenum, and you will have an indirect portal venous phase. So, but yeah, but stability is way more important than this, what I just mentioned. So if it's more stable further on, I just put it in the proper, or the right or the left, wherever you have to be. Sometimes you see additional lesions though. So if there's any chance, I prefer to, let's say, put the tip proximal to the bifurcation of the left and the right to see the entire liver, depending on the anatomy, of course. If you have an aberrant right or left.
Right, yeah, then you just have what you have, right?
Yeah.
Okay. All right, cool. Well said. That wraps things up. We'll see you next time with the BackTable podcast.
My pleasure. Thank you.
Martijn.
Bye-bye.
Super good, right? Hold on, let me, before you go, Martijn, let Josh come in and tell us